Frozen shoulder or adhesive capsulitis is something nobody wants to hear they have. If you've been diagnosed with this, then this video is for you. We're going to walk through the definition, how we diagnose it, the timeline of the condition, and how we treat it. Welcome back, team, to the Building Lifelong Athletes podcast. Thanks so much for stopping by. I really appreciate it. If we haven't met yet, my name is Jordan Rennicke, and I'm a dual board certified physician in family and sports medicine. And the goal of this podcast is to keep you active and healthy for life through actionable evidence-informed education. Today, we're diving in deep into something that we see every once in a while in clinics, something called adhesive capsulitis, or what most people know it as frozen shoulder. This condition can be super frustrating for patients, so it's so important that we have a good understanding of what it is and how to educate patients about it. So let's dive into it here. So first things first, let's talk about the basics of adhesive capsulitis. What exactly is it? Well, it's not just shoulder stiffness, right? Some people say, oh, my shoulder's really tight. That's what it probably is. Like, I'm just saying, as a clinician, when you see this, you will know it. It is not just like subtle, like, oh, a little stiffness. It is pronounced. So it's not just shoulder stiffness. It's serious. It's very insidious, though. It kind of gradually comes on. It starts with pain, maybe a little bit of loss of range of motion, but then eventually you have this big loss of shoulder range of motion. And that's the big thing. And the key thing here, kind of a big diagnostic criteria, is that the restriction is going to happen with both active and passive range of motion, meaning the patient can't move themselves and you as a clinician can't move them either. It's like hitting a wall. Honestly, when I teach people this, I say you have to feel like it's like you're literally hitting a wall. You're trying to move their arm, like external rotation or something, and like you can't do it. You are hitting a wall. That's usually when you say, oh, snap, like this could be frozen shoulder. And that tells us the problem is going on deep, right? Deep into the capsule, into the shoulder joint itself, not just something else going on. And what is actually going on in there? Well, we're not entirely sure, but we think that initially it starts with inflammation, right? That triggers a lot of the pain, right? So we have inflammation, the joint's angry, it hurts a lot, but then eventually it shifts towards fibrosis. So kind of think of like a scarring that's going on here, and the capsule tightens up and then contracts down. That's what limits the motion. When I step back and say the joint capsule, all of our joints have these synovial capsules, right? They have synovial fluid, so fluid inside these capsules. I kind of describe them as plastic bags. So plastic bags are kind of malleable, they move, they can hold stuff. That's kind of what a joint capsule is. In this condition, what's happening is that capsule is getting thick and contracting down. That's leading to that loss of range of motion. So when I think about that, I think of a tightened, thick capsule. That's what's leading to the loss in range of motion. And the names have changed over time. It used to be called periarthritis. Then the catchy term frozen shoulder came on. And then more recently, in terms of, 1940s, not that recently, but they said adhesive capsulitis. They thought there were adhesions in there. Turns out when we look at things arthroscopically inside, there's no like real adhesions going on. It's more of like stiff, thick, and fibrosis. So, a lot of people call this adhesive capsulitis in literature, and now actually people are making a push to say it's actually called frozen shoulder. Doesn't really matter. Don't really care what you call it. We use them interchangeably. So frozen shoulder, adhesive capsulitis, that's really what it is. And so that's kind of the big thing here, though, is that it's going to be frozen shoulder or adhesive capsulitis. Don't care what you call it, but really what it is we're going to have this decreased range of motion, right? Significant changes in range of motion. And that's what you should be kind of cluing into, thinking, hey, this might be happening. So going into it, though, not all adhesive capsulitis is created equal. We can break them down into two main buckets, primary and secondary. So primary is kind of idiopathic, meaning I'm not sure. It's a fancy medical term for we don't know. I would say you're an idiot because it's idiopathic. We don't know what's going on. It just happens. But this is the big thing. We see strong links with other health conditions. Things like diabetes is a big one. I would say the vast majority of the patients that I see who have frozen shoulder happen to have diabetes. That's kind of what it goes to. Your risk of getting adhesive capsulitis goes way up. We're talking almost like 20-30% of diabetics may experience this at some point compared to just a few percent in the general population. So a big thing. On top of that, they also lead to the more tough and more stubborn cases. And it's like most things, usually diabetes doesn't help anything. Any medical condition you have, if you have diabetes on top of it, usually that makes it worse. And it's kind of the same for adhesive capsulitis as well. We're not sure why that happens, but that does seem to be the case. Additionally, there's thyroid problems that can be attached to this, both overactive and underactive thyroid. So hyper and hypothyroidism, both those can be linked to having this as well, but we're not exactly sure why. Could be a metabolic change going on, maybe autoimmune things are going on. Definitely not sure as well. And there also may be some connections to heart disease and Parkinson's, other things like that. But the biggest things are usually thyroid and diabetes. Secondary adhesive capsulitis is more straightforward, though. It happens because of something else. Maybe there was an injury directly to the shoulder, like a rotator cuff tear, or maybe we had trauma to it, something like that. A lot of the times what I see is following a fracture or surgery, right? So after a fracture or shoulder surgery, you have a pronounced period of immobilization. And that's kind of the big thing. When you immobilize your shoulder after a trauma or for whatever reason, there's a chance of it kind of contracting down, getting tight, and you get this frozen shoulder. And so that is something that can happen. It has also seen other serious conditions like stroke and heart attack sometimes after can cause frozen shoulder. But the big thing is usually a trauma or something like that. And once again, When we're talking frozen shoulder, we're talking like big range of motion loss. So when we're looking at it, it can be upwards to 50% of range of motion loss specifically. So I just wanted to mention that that's a really big thing. And so what are these clinical phases? Well, typically frozen shoulder goes through some distinct phases. So you have to remember the timeline's not set in stone though, right? It's going to vary quite a bit between people. Think of it as kind of like 4 main ones. So I used to be 3, now I kind of think of it as 4. So the first is pre-freezing. So this lasts anywhere up to about 3 months. It kind of starts subtly, right? The patient feels the ache and it's bugging them more and more. Maybe at night it's starting to hurt, and then you start to lose a little bit of motion, specifically when you're trying to turn that arm out, right? The biggest thing when we're looking at this clinically, the history is, hey, external range of motion. That's usually the first one to go. So when I have patients in clinic, I'm checking if they have great external range of motion. I'm not that concerned for frozen shoulder. But once again, that's a big thing. You're going to take the patient and you're going to bring them through external range of motion. And if they have a great range of motion on both sides, probably not frozen shoulder. But then again, if you hit the wall and you're like, oh shoot, they can't do anything, then I definitely think this could be going on. And eventually over time, it'll become more globally where abduction, internal rotation, flexion, all those things are limited, but external rotation is the first one. And so that's the big thing when testing. If we see decrease there, you start to think, could it be? And this is early, but in this early, pre-freezing stage, it's not that bad, right? At this point, it's kind of easy to mistake this for something else. And this happens all the time, right? People come in, a little bit of shoulder pain, a little bit of loss of range of motion, think, hey, maybe this is rotator cuff related pain, labor, who knows what. I'm not too worried about this, but hey, go do physical therapy and come back. This happens all the time because it's almost impossible to differentiate something else from early pre-freezing stage. That's, unfortunately, but that's kind of what happens. Then we move on to the next phase, which is the freezing phase. And this is where things start to get real and get nasty. Usually this is between around 3 to 9 months. And the pain really ramps up here. And that stiffness really starts to increase as well. And you start to lose range of motion. You get that big loss of range of motion in multiple directions, right? So both actively and passively, meaning they can't move it and the clinicians can't move it either. And the capsule's getting more and more fibrotic, more scarred down, and the pain is typically the worst at this stage. It feels like the shoulder's literally freezing up. This is one where I tell my learners, hey, it's on your differential of like when everything hurts, when the shoulder just doesn't make sense and everything hurts, you have to think of frozen shoulder because it can be incredibly, incredibly painful. And so that's something we have to consider, that someone comes in, you're like, this doesn't really make sense. Like there's no trauma to this and they're having decreased range of motion and it just hurts everywhere. We have to think about frozen shoulder. So this is that freezing phase of the second one, really, really painful, kind of happening anywhere from about 3 to 9-ish months, can be variable, depending on the person, but super painful, does not look like a good time. Then we move in from the freezing, right? So we're going from first one's pre-freezing, then freezing, and then now we're into frozen. This is where they are stuck. And this is usually from around, at 9 to 15 months. And here it's kind of, things change a little bit, right? So the intense pain starts to back off a little bit, especially when they're resting, maybe sleeping's not as bad, but the stiffness is still really extreme. So I kind of think about initially you had huge amount of pain and freezing's kind of getting there. And then eventually they kind of cross. And now we have a frozen shoulder and pain is getting better, but still bothersome for them, right? You're really going to be limited in range of motion and movement. And when you try to push it, there's this hard, once again, wall. It's like you're running into a wall. They can't do it. It's a firm endpoint. That's a big thing. I say, hey, does this have a firm endpoint? Talk about that with other orthopedic tests, but hey, it's like running into a wall. The capsule's thick, tight, and it's really challenging. It can be upsetting for them because it's tough to do even just your daily activities when you can't move your arm. And we're talking about literally people can't lift their arm up at all, like to the side or anything. They can't use it. And so it's really challenging to do your daily living of things when you can't use your arm. And then finally, after we have that, the last phase is the thawing phase. And this usually starts around 12 months, maybe. Who knows? It can take up to 2 years or 3 years to fully heal. That's the big thing. A time frame in this, it takes a long, long time. But in this thawing phase, motion gradually starts to come back. Pain is mostly getting better or gone, and the capsule starts to remodel itself again. And the cool thing is that most people do get better. They often get back to close to their normal function, but it can just take a long, long time. And so the biggest thing is that when you're talking to patients, you have to say, hey, this may take a long time, and set up expectations. Like, hey, this is gonna be the long haul. Like I've literally seen sometimes it takes up to 2 to 3 years for some people to get kind of back to where they be. And other people don't get fully back to where their baseline was. And that can happen. So it's not unheard of though to have a little bit of stiffness or occasional ache and pain for a very, very long time. But the biggest thing I would say out of everything in this lecture and understanding is that, hey, this can be in it for the long haul. So you have to counsel patients appropriately. Because if you think, hey, we'll be better in 4 weeks, it's going to be a hard time when they're at 6 months and they're like, why am I not better? It's like, well, because you were never going to get better at 6 months. We didn't have that expectation set. So just something to think about. And as I mentioned, the natural history of this is that it's usually self-limiting, meaning it'll just go away on its own, usually within 1 to 3 years. And yeah, it does happen for some folks, but there's definitely not the case for everyone. Just waiting it out sometimes may not be the best strategy because it can lead to other morbidity. So what I mean by that is if you just did nothing, right? So hey, like just have benign neglect. So you're fine, it'll get better, no worries. That can work for some people, but not for everyone, because while spontaneous recovery is the natural course, a pretty significant chunk of people actually end up with lingering issues for a long time if they don't get treatment. So we're talking about persistent pain, stiffness that just won't go away, and trouble with daily functions even years down the road. And so that's why I'm always a big advocate of we want to treat this. And yes, is it like life-threatening we need to treat? No, we don't need to do that, but it's helpful for their long-term prognosis to do that. Some studies suggest that patients still had some pain or stiffness 7 years after this. That can happen. Another study showed that 40% still had range of motion limits after several years as well. So self-limiting doesn't always mean a perfect recovery for everybody. That's where we want to kind of use all the resources that we have. And what makes the difference though in these people? Some people have better outcomes than not. Well, there's a couple different things. First is diabetes, right? Diabetes is a big one that often means that you're having a longer, tougher road. And how long you've had symptoms before getting help also may matter. Meaning if you wait too long, that could potentially lead to worse outcomes. Though the data is a bit mixed about that, I'll say as well. And also how bad the stiffness was initially seems to play a role. If it's really, really bad to start, odds are it's probably gonna be a little longer in recovery or may have a worse recovery, something to think about. And on top of that, if it's secondary adhesive capsulitis, right, caused by something like a trauma or surgery, the recovery path might look different depending on the original problem as well. So it's not like a simple A to B, everyone's going to follow this course, but just understanding that we probably want to get involved with physical therapy and treatment modalities, whatnot, to help improve the long-term outcomes. But even then, it may not matter. We could do an intervention and it may not help you, or we can do nothing and you're fine. Who knows? But we just have to offer things to patients and have options for everybody. And so on top of that, moving on, let's talk about the clinical diagnosis, right? So how do we do it? It doesn't, as we talked about here, it is a clinical diagnosis. So before I kind of mentioned that, clinical diagnosis means like you can just see them in clinic and make that. It's not just this run-of-the-mill stiffness that I mentioned before. It is really, really serious. It's going on and it's going to take quite a bit of time. And the big thing for diagnosis is just going to be clinical exam, right? So history and clinical exam is going to be like the big thing. When I say it's a clinical diagnosis, that means it's clinical in that you talk to a patient and understand. They're going to give you this history of, hey, it's been coming on for a while. I have this vague shoulder pain. It's getting worse. I'm losing some range of motion. Those are the big things we're looking at here. And specifically, they may have already had contact with the healthcare system. A lot of times they come in and say, hey, I had shoulder pain. They get sent to physical therapy. They don't get any better. And quite frequently, I'll see people in my sports clinic who were in physical therapy and PT sends them back saying, hey, I think they have a frozen shoulder. Our physical therapists are wonderful at that. They recognize it. They know to look for it. But in primary care, we should also look for that saying, hey, if we have this vague shoulder pain, it's not getting better, come on back and we can think about adhesive capsulitis or frozen shoulder. So we have to kind of think about those things as well. And maybe they have, when you're on the exam, you're going there and decrease range of motion in general, right? So you think about your external rotation. That's the first one to go. They're going to have decreased external range of motion. It's feeling like that endpoint, if it's really late on in that frozen stage, it's like a hitting a wall. But I always check that first and see how that's going. Then you'll check the other ones, right? So abduction, flexion, and then internal range of motion as well. Globally, usually you're decreased there. That's kind of what we see. From a palpation standpoint, they may have tenderness kind of all over the shoulder. There's not like one specific spot that says, hey, like you have frozen shoulder because it hurts here. That's not the case at all. But it sometimes have diffuse pain. And then with special tests, if they're able to do special tests, looking for the rotator cuff testing, those might be positive as well, just because the whole shoulder hurts. And so it's one of those ones where there's not like a one test gives you this. It's more of a, hey, I rule out other things, almost a diagnosis of exclusion, but it can definitely be clinical. And I have to think about that as well. And so those are the big things when I think about making a diagnosis, is that it's going to be clinical. So talking with the patient, get their history. That's so important. Don't just brush through them and move their shoulder and say it's whatever, listen to their history. Usually that gives it away in terms of the range of motion losses. Check for range of motion losses on exam. You can palpate if you want to, but a lot of times those are the big things. And then moving on, imaging. As I mentioned before, this is a clinical diagnosis. A clinical diagnosis means we don't need imaging, and so we don't need to do that. But a lot of time it's done to rule out other stuff as well, right? Because when people come in and their shoulder hurts so bad, you don't want to be like, oh yeah, it's just a frozen shoulder, if you don't know for sure, because there can be a lot of other stuff that mimics it. And so we always get x-rays first to start. That's just kind of how all radiology works. Where the big thing here is that we're looking to make sure they're not missing anything big, bad, or scary, right? Like really profound arthritis can look like this. Like you can lose range of motion with really bad arthritis. And it'd be foolish to say, oh, you have a frozen shoulder, we have really bad glenohumeral arthritis. So that's a bad look. So always look for that. Also, you can see calcium buildup, so calcium tendinopathy. That presents with a lot of pain as well. Maybe you see a fracture or you can see a tumor. The reason we get x-rays is just because we don't miss big, bad, scary things. But however, in straightforward frozen shoulder, the x-rays are usually completely normal. Maybe just showing a little bit of osteopenia because of not using it as much, but usually pretty normal. And then MRI, sometimes MRIs are got just because the range of motion is so bad. You're like, oh gosh, like what's going on here? So you can definitely get it. Not needed, but can be helpful. And what you'll see here is if you do that, you're essentially once again trying to rule out stuff like a big rotator cuff tear. If you have ultrasound, we'll talk about in a second, that can replace that. But if you do get an MRI, you might see a couple things. You might see thickening of the joint capsule, usually thickening over 4 millimeters is kind of suggestive of maybe adhesive capsulitis. And you may also see thickening of a specific ligament called the coracohumeral ligament. And so, if you see those reports in the MRI, they'll probably say concerning for adhesive capsulitis. But if you see thickening of the capsule or thickening of the coracohumeral ligament, think about potentially what's going on there. You might also see signs of inflammation, especially if they use contrast, which I don't know why anybody's getting an MR arthrogram necessarily for this. That's usually not the first line. But sometimes if you see that, you might see additional dye into the space called the axillary recess, which is kind of under the arm. That can be filled in more on MRI. You might see that more fluid there. And then also you could see even kind of how the capsule responds to fluid may also indicate that I have adhesive capsulitis as well. But once again, those usually overkill for most cases. If you're getting an MR arthrogram, it's usually because you're looking for like labral or something, but usually an MRI without contrast is acceptable. And then finally, we also have the ultrasound. Ultrasound is getting more popular. It is convenient. It has no radiation. You do need to have a skilled operator in this though, right? So you have to really, it's kind of subjective. You may see on ultrasound thickened coracohumeral ligaments. You can check the axillary recess to see if it moves when you rotate the arm, stuff like that. Maybe able to see some changes on Doppler. Regardless, that's not necessarily, I think, the main role of most people unless you're specialized in that. But the big thing that it's really good for is it can rule out big rotator cuff tears, right? That's like the big thing I use it for a lot of times is I'll look at those other things as well to try to see, but really what I'm trying to see is, man, I think this is a frozen shoulder. I want ultrasound and make sure, okay, the rotator cuff is not torn. Great. It's not a huge tear. Then it's frozen shoulder. We can go from there, save people an MRI and save them time as well. So those are the big things. Once again, you don't need any of those. You can make this clinical diagnosis on your own, but that is what we do and can be helpful. And so now let's talk about treatment, right? We usually start with conservative approaches and trying to avoid more invasive measures unless we need to, right? So the first thing first, as I mentioned before, is education. And this is huge. Patients need to understand what's going on. And, it's important to explain the stages, right? That this is a known condition and importantly that this typically does get better, but it's going to take a lot of time. The biggest thing from patient education is understanding those expectations. I say it all the time. When I'm telling people about rehab, I usually tell them, hey, you've been having pain for a while. It's going to take multiple months to get better. A lot of times people think, oh, I'm not better in 4 weeks in physical therapy. Oh, why not? Like if you set that expectation that I wouldn't expect you to be better in 4 weeks, that's really helpful. Same thing here. Telling them, hey, this is going to be a while. It does get better, but it's going to take a while, months, or maybe even a couple years. So setting realistic expectations from the get-go is crucial to keep them engaged and prevent frustration, right? And we also need to talk about modifying activities as well in this process. So I always tell people, don't push into sharp pain. Like if you have take your breath away pain, don't do that. You don't have to push into that. It's not helping it. You're not going to necessarily change the course of the condition. So just pull back a little bit. But I also don't want you to immobilize completely, like just sitting in a sling. I want you to use it. Kind of gentle motions that you can tolerate is really key. And I just kind of say motion is lotion. In this situation, it's very, very true. We want to keep moving as best we can, but we don't want to push through crazy amounts of pain. On top of that, we can take medications to help with pain. Obviously I prescribe those judiciously. I don't do a lot, but when you're in a lot of pain, sometimes it can be helpful. Things like NSAIDs can be helpful and can take the edge off the pain, maybe calm down a little bit of the inflammation. The evidence isn't super strong that they dramatically change the course of this condition at all or improve range of motion at all, but they may just make you feel better. And sometimes that's worth it, just feeling better. So we have to think about that. But once again, anytime with NSAIDs, just got to think about the other side effects, GI issues, kidney issues. If you have a heart disease, probably wouldn't take those. So don't just be popping Advil, talk with your physician first, obviously. And then oral steroids, sometimes they can be indicated. So a short course of steroids, like a taper there, may be helpful for some patients, particularly early on when things are really inflamed and painful. So it can offer a pretty dramatic short-term pain improvement and maybe might speed up initial range of motion improvements. The catch though is that obviously the benefits don't last forever. Once you stop the meds, a lot of times the pain improves for a while and it may come back, May or not, we'll see, but also has other side effects of steroids, right? So you can mess up blood sugars for patients who are diabetics, can lead to mood swings, sleep problems, technically increases the risk of infections. And so these are kind of reserved for people with really severe pain that's really wrecking their sleep or making it impossible to even start therapy. So that's kind of how I think about oral steroids. Systemically have a place, but they're a big gun, and I try not to use them if possible. But sometimes when people are miserable, we got to do what we got to do to help people live a normal life and get some sleep. And then moving on to the real workhorse here of treatment is physical therapy. So physical therapy is pretty much essential, especially once you're past that initial super painful phase into the freezing and frozen stages. So what are we trying to achieve in physical therapy? Well, the goal really is to get that motion back, maintain the motion we do have, right? If it is still freezing, trying to hold on to what we got, and then help people function better in daily life and keep their pain manageable. Main component of physical therapy here is stretching. I think a lot of times you'll hear me rag on stretching, saying stretching is a little bit overrated. In this situation, like that's what we got to do. We're gonna have to stretch because we've lost so much range of motion. We're trying to get that back. So it's this gentle, low load stretches held for a decent amount of time, right? So kind of passive stretches where either the therapist or gravity does the work to start. Then active assist where the patient helps, and eventually the patient can take over and do all the stretches themselves. But it's kind of this gradual, slow progression. And we really want to be gentle here in these end ranges of motion, right? So external range of motion, abduction, flexion, internal range of motion, all of them are there. We're gonna be gentle and hold it there. The key is consistency though, right? We're doing these regular, right? These little doses of stretching. That's gonna be way better than just one aggressive time per week. So really kind of slowly doing that. And as I mentioned before, don't be too aggressive, especially early on. Trying to force motion when it's really irritated can just make things worse and set you back. And so gentle persistence is gonna, really be our key here. And there's also things that physical therapists can do called joint mobilizations. This is where the therapist uses their hands to glide or move the joint. These are definitely helpful at times. They can be nice because you get a little more range of motion there. It might give a little bit of extra boost to that stretching program. And yeah, it may help with pain as well. So yeah, there's multiple studies that show a benefit, but however, others show maybe it's not as important long term. Either way, it's one of those things where we're just kind of seeing how it goes, seeing if it helps with the progress, helps with their pain, and it's generally safe, and we just got to be smart about it. And what about things like heat and ice? Sure, they can definitely help make people feel better and maybe relax the muscles more, but overall, it's not going to change anything, right? I tell people that all the time. They're like, should I do heat or ice? I don't care. Not to be mean, but it doesn't matter. Whatever feels better to you is fine, because neither of those things are going to heal this process, but it's going to help you tolerate things better, then great. Things like therapeutic ultrasound and TENS unit as well. Evidence is that they actually don't really do much. They don't speed up the recovery. They don't change the underlying condition. So you can use them if it's helpful, right? So if you're in a lot of pain, and TENS or ultrasound makes you feel better, then great, that's fine, we can do that, but just something to consider. And then finally, strengthening comes later. Once the emotion starts to come back and pain's under control, then we can start adding exercises back to build strength, the strength that we lost from not using them, right? So we focus a lot on the rotator cuff muscles and scapular stabilizers as well. And so those are a couple of the big things, but that's the general way that we think about physical therapy. And then what if that doesn't work, right? So we did a bunch of stuff, all the conservative stuff, took some meds, did PT, didn't work. Then we start thinking about interventions, right? And they're a bit more involved. The first is a steroid injection. So this is probably the most common intervention from a physician standpoint. We're talking about injecting some sort of steroid medication into the actual glenohumeral joint, so the ball and socket joint. Think about that ball and socket. That's where we're going to inject that medication. And what does it do? Well, it's pretty good at providing significant pain relief for several weeks, maybe even a few months. And by calming things down, it may sometimes lead to faster improvements in range of motion compared to just doing PT alone. The big advantage here, though, is that it's reducing pain and allowing patients to actually tolerate and participate more in therapy. That's what I say all the time. Steroids are almost never like a curative injection. That's not always the case. Sometimes it actually may be. But in these situations, the real reason I use these is to help patients tolerate therapy. When they can't sleep, when they're in pain all the time, a steroid injection sometimes just calms things down so you can get on with your normal life, get some sleep, and start to do your therapy. And that's what I use it for predominantly. I don't think I'm ultimately fixing it. And if it has the benefit of maybe shortening it, great, then that's wonderful. But I'm not convinced by that data, but it's something to think about. However, the evidence does generally back it up for short-term gains. Some studies even suggest it's better than taking oral steroids or just doing PT initially. I like this over oral steroids because it's going to be more localized instead of just taking steroids, it gets everywhere. This is going to stay a little bit more in the joint. We know there's some absorption of any injection systemically throughout the body, but it's more targeted here. But yeah, do I think it makes a huge difference in the final outcome compared to just sticking with PT and at a year plus time? Who knows? Not necessarily, but it maybe provide valuable relief early along the way that people need. And so that's what I think about. And from an injection standpoint, you can do this. You can try this landmark. Ultrasound is just going to be a way better way to go. Ultimately, we know that medication is getting into the joint capsule where it needs to be instead of accidentally going somewhere else there. You can still do a subacromial injection there, and that may get some benefit. That's actually that's what you know, and you can help them. That's fine. But ultrasound, if we have it to get actually inside the joint, that'd be ideal. And as we mentioned before in previous podcasts and videos, we've talked about that. Yeah, when you have injections of steroids or anytime you can have complications, the biggest thing is that you can weaken the tendons with steroids, especially if you do lots and lots of injections. You may also get some thinning of the skin or loss of skin pigment as well. And then can also spike blood sugar levels with diabetics, as we've talked about before. Also increases risk for infection around that area. So just some things to think about there. I have additional modules on injections and all that stuff there, but that's worth mentioning. Another thing I want to talk about is called a hydrodilation, or sometimes called a hydrodistension. This is kind of the next level up, kind of intense. And what is it? Well, it's basically just injecting a lot of fluid into the joint capsule. Usually it's a mix, it's kind of like a cocktail of a steroid, some normal saline, or mixed with some sort of local anesthetic. So a lot of times it can be steroid, anesthetic, saline, dextrose. It could be lots of different things, but we're injecting some mixture into the actual joint capsule. And the goal is to physically stretch the tight capsule down from the inside out, almost like we're inflating a stiff balloon. That's kind of how we think about it. And for this one, though, you're going to absolutely need imaging, right? You can't just do that landmark. You're not going to know. Usually you can do ultrasound, or you could do fluoroscopy. I do ultrasound, but we're going in there, we're literally just putting fluid in there, trying to just pop open that little plastic bag a little bit, not necessarily pop it, but kind of make it a little more space, not quite as thick. And the idea is that, how does it work? Well, partly it's that we're physically stretching, or maybe even causing some small micro tears in the capsule in the tightest parts. But it may also wash out some of the inflammatory molecules that are in there. That's another idea that's going on. And that's why maybe the steroid may be beneficial. I don't do a huge amount of steroid, but you could do a little bit there. And what does the evidence say? Well, several big reviews, including meta-analyses, have looked at this, and they generally suggest that hydrodilation can be quite effective for both pain and improving motion. And some research indicates it may be better than just a standard steroid injection or PT alone, particularly for those earlier in the process as well. But the quality of these studies varies, and there's lots of debate on this and how much fluid to use. That's another big thing, is people don't know what's going on. It is an office-based procedure though, so it's usually not on the OR or anything, but it's done under some sort of guidance, and it can be very uncomfortable though, right? So when you have a fixed amount of space in your body and you're putting more fluid in there, it just leads to a lot of pressure. And so it can be very painful and uncomfortable. And there's no one cocktail that people use. It could be anywhere from 10 milliliters. So I've seen people say 30 plus. And so literally just putting tons and tons of fluid in there. I don't go that far. That's barbaric. I've even seen some people say that, hey, you should inject until you break the capsule. And for me, I'm not trying to do that, but that's how much volume we're talking here. It can be a lot. But the big thing is, after we do this, we definitely still want to get physical therapy afterwards to maintain this. So if you stretch out the capsule, get a little bit of range of motion, we really want to get you to PT fast so we can keep that range of motion. And as I mentioned before, not that comfortable for patients. It can be uncomfortable. And so this is one you definitely talk with them to say, hey, it's an option. But if you're sitting there in your primary care office and saying, hey, I don't know what options I have, you can send us to sports. We can absolutely do these things. So I just want to mention that it's definitely out there, and the data seems to be supporting of that it can be helpful for patients. And so what happens though now if you've gone through months of physical therapy, tried a couple injections, maybe just steroid and a hydrodilation, and they're still stuck and miserable, and we're 6+ months out from this? Well, then we have to consider, should we have this patient talk with a surgeon, right? They're not the first line treatments. This won't be there. We reserve them for really stubborn cases. One option is manipulation under anesthesia. And here the patient gets completely under general anesthesia, and then the surgeon potentially carefully moves the shoulder around. We're just kind of breaking up adhesions is kind of what I think about it. The scar tissue kind of literally just aggressively stretching them is what we're doing, and trying to open up that capsule a little bit. And it can be pretty dramatic, and it can sound awful if you're in the OR and you hear this, it can make a crazy sound. It's pretty intense, but yeah, a lot of times when you do this, it does have risks. So the first things first is that if you just did it and go back to normal life, you'll go back to being scarred down. So we have to once again do it and then go right to physical therapy to keep those gains. And on top of that though, it's definitely risky because you have to put a lot of force into it. And if you put a lot of force, you could theoretically break someone's arm or shoulder. That would be bad. You could potentially dislocate the shoulder, tear the rotator cuff, cause a nerve injury. Because it's kind of pseudo-barbaric, a lot of times this is not taken lightly, right? If we're going to do this, it's because we really thought about that. But it's not necessarily a huge one that I see all the time, but it's an option that we have. And then another surgical option we have is an arthroscopic capsular release. And this is a minimally invasive surgery where essentially you make tiny incisions into the shoulder joint, put something inside, and inside there use special instruments to kind of cut and work through these tightened, thick areas of the capsule. And usually they're focusing on the anterior and inferior parts of the capsule in a kind of area called the rotator interval. But these are like wherever they see the tight spots there, it's kind of where they go in there and try to break that up. And yeah, it's cool because you're using the camera to see along the whole way. Surgeons feel this is a little bit safer, more controlled way to kind of restore motion, but it's still a surgery. So you have your standard risks of infection, bleeding, nerve injuries, anesthesia risks, all that stuff. And once again, we'll need physical therapy after, but these can be the tools that we have if we've been doing things for a while and not getting any improvements. And so that's kind of where we're at. I just want to wrap up the main points here, right? This is a lot that I've been talking about here, but just kind of take home points, 20,000 foot view. First, remember that frozen shoulder, it's this insidious onset, gradual locking of the shoulder. It's painful. You're going to have loss of range of motion in both active and passive ranges of motion. That's the big thing. And so we're going to see in both sides. And there's two different types, right? Primary, the kind that just shows up, sometimes associated with diabetes, but not sure. And then secondary, which is linked to an injury or trauma or something like that. And to make the diagnosis, it's clinical. Listen to the patient's story, and then exam findings of globally reduced range of motion may kind of cinch the deal for you. And you can use imaging. I think it's probably wise to get an x-ray first, just to make sure we're not missing anything big, bad, or scary, but don't necessarily have to do it. And then the duration of this, it's long. It will get better on its own, or it should get better on its own, but may take up to 1 to 3 years. And just telling people to wait it out probably is not ideal. We want to get them rolling with physical therapy and kind of get going. And from a treatment perspective, we work it step by step, right? So start with education so they understand. Then you can work in some, NSAIDs or oral steroids potentially if they need to. We can also really get them involved early with physical therapy to focus on gentle stretching and kind of improving their range of motion if possible. And then if we need to escalate, think about steroid injections, right? So hopefully ultrasound guided, but at least steroid injections into the glenohumeral joint or a hydrodilation may be helpful. And if, last case, that's not working, we can refer to surgery to see if there's a surgery that needs to be done. But the bottom line is that often it takes a combination of these things. And maybe most importantly, we need to just help our patients understand that this is a marathon, right? This is not a sprint. It's going to take a long time. We need to have some patience, persistence, and just kind of realistic expectations will be really, really helpful. And that's a wrap on adhesive capsulitis. Thanks so much for tuning in and sticking with me through a lot of that nerdy stuff. I hope this breakdown was helpful and gave you some practical insights you can use. If you did enjoy this, it would mean the world to me if you shared this with a friend, gave it a 5-star review in your podcast platform of choice, or subscribed on YouTube. And so that's going to be it for today. Thanks so much for stopping by. Now get off your phone, get outside, have a great rest of your day, and we'll see you next time. Take care.